Behavioral health demand has reached a historic peak across the country, yet many clinics are effectively closed to new patients. Using 2024 SAMHSA data, grow another 62% by 2036. The bottleneck is operational. Administrative barriers prevent practices from accepting patients, even when space is available. Most owners find themselves on a staffing treadmill, where patient capacity is dictated by the speed of administrative churn rather than clinical need. Data from NYC Health Plus Hospitals puts the national behavioral health turnover rate at 31%. This constant cycle of hiring and replacing staff creates a permanent ceiling on growth. Clinics cannot solve this access gap by simply increasing caseloads, because the existing administrative systems are already operating at their absolute limit. To understand why these systems fail, we have to look at the specific workflows inside a mid-sized practice. Behavioral health documentation requires a unique approach. Therapists generally cannot chart during a session without interrupting the therapeutic alliance with the patient. Because documentation happens after the session, JotPsych reports that nearly half of behavioral health providers spend 5 or more hours every day on administrative tasks. This leads to pajama charting, a phenomenon where clinicians finish their session notes at home late into the night just to stay caught up. This immense workload is measurable. PIMSI EHR found that 82. When a staff member resigns, the remaining team absorbs extra work, triggering burnout and the next resignation. Evolving compliance requirements like HIPAA and MHPAEA parity rules add even more weight to this cycle, requiring specialized documentation from exhausted teams. This burden is an active career hazard. It shortens the professional lifespan of clinicians and disrupts the continuity of care that patients rely on. The standard response to this crisis is to hire more full-time in-house administrative staff. This chart breaks down the true cost of a W-2 hire. A $35,000 base salary actually reaches $60,800 annually after benefits, taxes, and turnover. Plus, the horizontal axis shows a time cost, 4 to 6 weeks of training before full productivity. For a practice owner, this means committing over $60,000 in annual overhead to a role that has a 1 in 3 chance of being vacant again within 12 months. MGMA data shows medical group leaders spend the majority of their time recruiting and interviewing, rather than focusing on quality of care. A physical office presence may feel easier to monitor, but it requires the practice to carry all financial risk when that employee leaves. Relying on the traditional W-2 model to scale leads to higher overhead and recurring operational disruptions. A different approach separates clinical and administrative work by using specialized virtual medical assistants to break the scaling bottleneck. This matrix shows the Staffingly model. A virtual assistant costs $21,600 annually, a 64% savings over in-house hires. They operate within a HIPAA-certified, SOC 2 compliant, HIT Trust-aligned system. Furthermore, EHR deployment takes just 48 to 72 hours, bypassing the 6-week traditional training phase. The model includes its own management structure, providing a team leader, a process manager, and a customer success manager to oversee day-to-day quality. Smaller practices can also use an hourly model, with rates between $9.50 and $12 per hour depending on the volume of work required. This converts unpredictable staffing liabilities into a fixed, scalable utility for the practice. The efficiency of this model comes from pairing trained specialists with a proprietary AI layer that augments their workflows. The system uses natural language processing to extract and pre-populate data from intake documents, which eliminates the need for manual data entry. Automated duplicate detection identifies redundant entries before they can lead to billing denials or documentation errors. This dashboard highlights the predictive scheduling module. It analyzes practice patterns to suggest the most effective times for patient outreach and follow-ups. The AI layer also provides automated performance benchmarking, allowing the practice to compare its operational metrics against industry standards in real time. This combination of human coordination and AI tools resolves the documentation bottleneck more accurately than manual processes. The trade-off is specific. An owner exchanges the physical presence of a front desk employee for a 64% reduction in administrative overhead. This is ideal for solo and mid-size practices that are currently over-leveraged by documentation and prior authorizations. However, this model is not intended for clinics that require a physical security presence or on-site patient chaperones. For those who make the shift, most practices report a measurable return on investment within 60 to 90 days. Entry is low risk, with a 2-week pilot period and a 30-day satisfaction guarantee that ensures quality benchmarks are met before payment. To see if your practice is a fit, visit staffingly.com or call 800-489-5877 to speak with a behavioral health specialist. Solving the access crisis starts with reclaiming the clinician's time. Often, the most effective hire is the one you never have to manage in person.